All right, everyone. Welcome to this issue of, or this version of the AMSSM National Online Fellows Lecture Series. My name is Eliot Hu. I'll be moderating today. Today we have an excellent speaker, Dr. Steele. He's going to be talking about tendinopathies of the elbow. I'd like to welcome you all today. First, a couple of ground rules. This is sponsored by the AMSSM Education Committee and Fellowship Committee. We are an official subcommittee, and it's called the Online Fellows Education. So this should only serve as an adjunct to your individual program's educational programming, and it provides fellows with direct access to educational experiences with AMSSM members, and at times invited guest experts in a variety of formats. This is meant to assist in your CAQ exam preparation. When you join, please mute your device's microphone and turn off your video. And if you have any questions, we will have a Q&A session at the very end. So please submit your questions through the chat function. You can choose to include your name in your program if you want. I will be moderating that, and we will try to get through all the questions, time permitting. After the program, please complete the evaluation, which will be sent at the end of the lecture. So without further ado, I'd like to introduce our expert speaker today. Dr. Steele is board certified in family and sports medicine, and he is a nationally renowned physician who has been the program director for Eisenhower Health Sports Medicine Fellowship for the past 6 years. He is also the medical director of the Eisenhower Primary Care 365 Physician Group at Eisenhower George and Julia Argyros Health Center, and is a past president of the medical staff at Eisenhower Health. For the past 26 years, Dr. Steele has been covering major professional sports events in the Coachella Valley, including the American Express, formerly Bob Hope Classic PGA event, ANA Inspiration, formerly Kraft Nabisco LPGA major tournament, ATP WTA BNP Paribas Open Tennis Tournament at the Indian Wells Tennis Garden, the Skins Game, and the Lexus Challenge. During this time, Dr. Steele has been a staff physician for the College of the Desert sports teams and co-manages the Eisenhower Sports Medicine team, supporting local college sports and several local high schools. A United States Navy flight surgeon, active duty and reservist, Captain Steele retired after 32 years of proudly serving the United States Navy and Marine Corps personnel. He is a former board member and fellow of the American Osteopathic Academy of Sports Medicine. He is a holistic integrative, he takes a holistic integrative approach to medicine, and it has been the foundation of Dr. Steele's practice for his entire career, including proper lifestyle modifications, diet, exercise, and manipulative medicine whenever appropriate. He advocates that this approach will often limit or eliminate the need for medication. Here's a quote from Dr. Steele. "I certainly enjoy caring for the best athletes in the world, such as professional tennis players, golfers, and pickleball players that come into town annually. However, my true calling has been developing a relationship with, caring for, and advising my regular patients and athletes. I particularly enjoy establishing an integrative approach and watching the positive changes come over time." Without further ado, I'd like to introduce Dr. Steele. I will not, now I will stop sharing the screen, and Dr. Steele, please take it away.
All right, let me make sure I got this. Let me know if you see my title.
Perfect.
Okay, great. Well, thanks very much, Eliot, for asking me to prepare and give this lecture tonight. And as you heard, we get to see the best tennis players and golfers in the world come through here every year. The BNP is the 4th largest tournament in terms of the attendance in the world, and it's the 5th largest purse. So all the players do like to come here. We pretty much see all of the major players, men's and women's tennis players, as long as they're healthy when they get here. But the bread and butter, kind of like Eliot had gone through, is my office practice is, you know, a group of 50, 60, 70-year-old, 80-year-old athletes that came here, moved here, come here in the winter time to search out the great weather and play their racket sports, their golf, swim, and you know, caring for them is the mainstay of our practice out here and in the fellowship. So trying to advance the slide. There we go. So I have no financial disclosures, conflicts, or industrial support for this talk. What I'd like you to glean out of this talk as we're done is that you understand the presentation of most common tendinopathies of the elbow. You're aware of the differential with those complaints, and that you're aware of the latest treatment options for people with tendinopathy of the elbow. So also remember that we're consultants a lot of times. We're not just the first physician these people see. So they may come to us and we actually need to look for the complicated case, the zebra, not the horse. So we do need to be fully aware of these differentials when we get somebody with epicondylopathy. So let me go over the anatomy. So we know the joint is a complex hinge joint with a humeral ulnar joint and the humeral radial joint. It allows for full extension to 0 degrees and 150 degrees of flexion, with the radial ulnar joint and the interosseous, with the neutral position being the elbow at 90 degrees and the thumb pointing straight up. We can supinate and pronate on average about 75 to 90 degrees in each direction. So quickly looking at the anatomy here, the supraepicondylar ridge is important because of some muscle attachment. We'll talk about the medial and lateral epicondyle. You can see the capitellum articulates with the radius, the trochlea with the ulna. But the coronoid, we have the coronoid process, which as you fully flex, abuts up into the fossa and is one of the constraints and limits the range of motion and deflection. And on the posterior side, same anatomy, but you see the olecranon fossa, where the olecranon into full extension abuts into the fossa and limits full extension. Some people are born to be a little hyperflexible due to ligamentous stuff and genetics. But notice again, this is where all the attachments are to the important muscles we're talking about, both the supraepicondylar ridges, the posterior part of the lateral epicondyles where the anconeus is, but we'll get into that a little bit more. The ulna, proximal ulna, has the greater sigmoid notch where it articulates with the humerus, and it has the lesser sigmoid notch where it articulates with the radius. And that joint allows the radius to rotate on the ulna as well as the interosseous, allowing it to rotate over the ulna distally to supinate and pronate. We also see the ulnar tuberosity. Here we see the head, the neck, and the radial tuberosity. Now with it all together, then you see where that radial head sits into the lesser sigmoid notch and articulates. Some muscles now. So anteriorly, we see the biceps. That's kind of the central thing here. The long head of the biceps tendon attaches distally into the radial tuberosity that we see in the cartoon over there on the left. But interestingly, the brachialis, dives deep to the biceps and attaches to the ulnar tuberosity. This is that crisscrossing allows for the biceps, when the elbow's flexed, to function as a supinator, and when the elbow's flexed, the brachialis functions as a pronator. The brachioradialis, so the brachialis comes off the lateral distal humerus. The brachioradialis comes off the supracondylar notch. On the medial side over here, the pronator teres comes off the epicondyle and the supracondylar notch. So it's sort of edged there. We'll see a little bit more about that. But the other head of the biceps, the aponeurosis, comes onto the superficial fascia. And so now we'll look at the medial side of the elbow. So we talked about the pronator teres and how it comes off of partly the supraepicondylar area. So, begin thinking and feeling for that when we're trying to differentiate what the origin of the problem is. The most common muscle to get tendinopathies on the flexor side, on the pronator side, is the flexor carpi radialis and somewhat the pronator teres. And then we have the palmaris longus, the flexor digitorum superficialis, the flexor carpi ulnaris. We do see a lot of racquetball athletes with flexor carpi ulnaris problems, but it's often at the wrist. So in the future, you guys might want to make sure you study all the pathology that occurs with the flexor carpi ulnaris at the wrist. We see a lot of that at the tournament. So this is all the common extensor flexor tendon. On the medial side, remember the palmaris longus attaches superficially under the aponeurosis of the palm and goes across the flexor retinaculum. It's superficial to that, so it's a good landmark when we do medial nerve issues at the wrist. On the lateral side, the most lateral over here, the extensor carpi radialis longus and brevis. So the most common tendon involved in extensor lateral epicondylopathies is the ECRB. Remember the ECRB and the ECRL traverse distally into the wrist and attach through the extensor compartment 2, the second extensor compartment, into the second and the third base of the metacarpals and our powerful wrist extenders. The extensor digitorum is the powerful finger extensor, which will come into play in the exam. Extensor digiti minimi and the extensor carpi ulnaris are also come off the common extensor tendon. The Inconius comes off of the posterior elbow. That's more of a stabilizer, which we'll talk more about as we go along. The supinator, deep to all that on the lateral epicondyle, wraps around the radius, attaching distally, anteriorly on the radius, allowing it to shorten and sort of twist the radius into supination. And along with the biceps are the supinators. And some genius, decided that we screw a screw in with supination and clockwise rotation with our right hand anyway. Most of us are right-handed. And we're more powerful with that than we are unscrewing when we use the pronator teres and a little bit of the brachialis, which is a smaller muscle. Just a little factoid. So the posterior elbow, we see the triceps, and they see the long head of the tricep comes off the inferior lateral portion of the scapula, and the lateral head comes off the proximal humerus posteriorly, and the median head comes off the distal, and they all attach onto the acromion. Well, we're not doing a ligamentous injury talk, but just to know that we're all on the same page here by the time we get to the conditions we're going to deal with, and for the differential, we talk about the ligaments of the joint. Remember, all synovial joints are completely encased by ligament capsule. So we see a depiction of the anterior capsule, depiction of the posterior capsule here. On the medial side, the ulnar collateral ligament is in 3 different bundles here: the anterior bundle, the posterior bundle, and the transverse bundle. So when we do some valgus stress on the medial side of the elbow, or depending on what position, those tend to tighten up and be the restraints in motion. The lateral side of the elbow, we have the radial ulnar collateral ligament that attaches onto the annular ligament in the radius. But also very importantly for constraint is the lateral ulnar collateral ligament that goes from the radius to the ulna, but it sort of helps hold the radius in as well as the annular ligament. The nerves traverse through the elbow, of course. So just quickly, the radial nerve traversing here, anterior laterally in the elbow, branches off its terminal motor branch called the posterior interosseous nerve, diving into between the 2 layers of the supinator here laterally, and can get in trouble. We'll talk about that later. The median nerve, midline anterior, also has a terminal motor branch called the anterior interosseous nerve that branches here. And it branches and dives in between the 2 layers of the pronator teres. So it helps you understand they're both pretty similar there. The ulnar nerve travels posteriorly on the medial side of the elbow. And as I said, they can each get in their own little problems. In the differential here, we know that medially we can have cubital tunnel syndrome. We can have snapping. Snapping elbow is often the ulnar nerve here medially dislocating or subluxing over the medial epicondyle. The triceps can actually also, in sort of maximum flexion, rarely dislocate over the epicondyle, medial epicondyle as well. And that's another cause of snapping elbow. But you can see the median nerve as it comes down through the elbow and bifurcates into the AIN, and it travels between the two layers of the pronator. And here you see with the muscles laid on the posterior interosseous nerve diving through between the two layers of the supinator at the arcata fruche, where it can get entrapped. The vascular really, more important in trauma, but just to make you aware, it's kind of tenuous with the recurrent branches and the way it circulates. And we're just going to want to make sure we test for vascular continuity. And then the stability, because of the bony constraints and the ligamentous constraints, in the stable situation and the static situation, the bones and the ligaments really take the most of the restraints of the movement of the joint and stability of the joint. So the medial collateral at 90 degrees takes up 50%, and the bony restraints the other. And on the lateral side, the coracoid helps hold things in place, as well as the lateral ulnar collateral and radial collateral and ulnar. But when we're moving, when we're in dynamic situation, when we're serving a tennis racket, the deep muscles around that, just like the rotator cuff is our stabilizers in a dynamic situation here, the deep muscles like the anconeus, the pronator teres, the supinator are all stabilizers as we go through motions with our elbow. So let's talk a little bit about the sort of continuum of the stages and histopathology of the tendinopathies. So the normal tendon here depicted in this cartoon on the left side of it is a normal tendon. The normal tendon, glistens white. It's got tightly packed parallel bundles of collagen fibers. It's got extracellular matrix that's basically absent. It's got inconspicuous vascularity. You can see like one depiction of a blood vessel down there. There's tenocytes that are generally also lacking or inconspicuous. They're thin and layer themselves, so they're hard to see. And very few, if any, fibroblasts and microfibroblasts. As opposed to the lateral, the right-sided picture here, you can see a gross thing that's sort of a calcific tendinopathy forming that we can see. But then the irregularly non-linear, non-tightly packed fibers, we'll see hyaline in between, hyaline between the cells. Hypertrophic immature fibroblasts, poorly organized collagen, and the fibroblasts. So hypervascularity. So here again in A is the normal tendon, tightly packed parallel bundles of tendon, inconspicuous tenocytes. Down in the B is the abnormal tendon. You can see hyaline areas, vascularity, different take-up of dye, which suggests more scar tissue type fibers mixed in with the tendon fibers, and more cellularity. So it's a continuum of reaction at first, and if the participant doesn't listen to their body, then they keep battering at it, causing more microtrauma. And even though we have protective mechanisms to try to heal, we overpower that with our thick skulls, and we end up with early tendon disrepair and then late tendon disrepair and degeneration. So that's the current theory of how this all arises. So then we move to the exam of the joint. Of course, as we all know how to do this, we inspect, looking for inflammation, and ecchymosis and deformity, palpate for the maximum point of tenderness, depending on the problem area, the range of motion. This is when I kind of get to pimp my fellows in the early part of the fellowship, friendly, of course, and say, did you do a full range of motion exam on the elbow? And they go, yes. And then I go in, and sometimes I catch them and the patient actually has a flexion contracture. They didn't really fully do it because they don't come in telling you they have a flexion contracture. They say they have a sore elbow. And if you don't think about it, they don't think about it. And you got to include that in your physical therapy or your plan. to rehab, and if you miss it, you won't be able to help them thoroughly. Checking stability with varus and valgus stress, motor and sensory, vascular, and then the provocative test, which we'll talk about with each problem. All right, so lateral epicondylopathies. Tennis elbow, repetitive overload, repetitive microtrauma with initial reaction and then slow degeneration. The location is that common extensor tendon off the epicondyles, of course, and this is 4 to 10 times more likely than medial. So all the research is done on the lateral epicondylopathies and on the Achilles. There's very little research on medial and the other tendons. So we have to extrapolate for a lot of that. So, again, we sort of have a failed reparative process that occurs here when these people come in because their body should have tried, but they didn't listen to, their complaints. But the epidemiology on lateral epicondylopathy it's generally in the 4th and 5th decade, although we see the competitive athletes at younger ages. We see them in their 20s and 30s because they've played so much more than the average person. It's mixed between male and female, throwing and racket sports for sure. But remember, if you're a primary care doc like me, you see laborers too, people that work hard, grip, and have vibratory equipment, like those classic guys out on the streets that are pounding down the cement with those vibrating things. Those are just much more likely to end up in the doctor's office, work comp issues. So just to think of them as well. We're not all just sports medicine, some of us. Repetitive wrist extension. So, the backhand. The backhand, we sort of extend our elbow and we forcefully supinate to put a topspin on the ball in tennis. The racquetball, and pickleball, they're doing that very quickly as well with a much shorter backswing. So we might think about technique. This is where we want to make sure that we get the coach, the swing coach, the athletic trainer, the physio involved to look at their technique, their sequencing, and their biomechanics, because a lot of times it comes from an incorrect swing that can be worked on before they go back to return to play. 10 to 50% of all tennis players are going to get this. Remember, it's the ECRB that's the most commonly involved. So this is our differential. Of course, we're first thinking of lateral epicondylopathies, but and we preach to examine the joint above and below the affected joint, but in this case we're thinking about the shoulder, but we do need to think about the neck. So radial, cervical radiculopathy, and doing a Sperling's test, something like that. Lateral, so little leaguer's elbow in the younger population, valgus extension overload in the older population. Lots of degenerative stuff can happen in those joints and hurt laterally or medial or posteriorly. Radial nerve entrapment, since we're talking about lateral elbow pain, we have to think of the PIN, osteoarthritic lesions, OCD lesions, supraspinatus, Supinator itself can get in trouble with supinator syndrome, and conius can be strained. And then again, we're primary care doctors, so we think of, do they have symmetric bilateral symptoms? Do they have something else? Or they have more systemic issue, rheumatoid arthritis in any age. My son came down with juvenile rheumatoid at 13, PMR, and then also medication side effects are possible. So we've got to think of all those possibilities. So on the exam, like I said, swelling, ecchymosis, and or deformity laterally. They might have a little swelling if they've really let themselves go. Palpating over the lateral epicondyle should be the most tender spot. Range of motion, again, making sure you do a full extension, full flexion, and rotation. I always go through that. Stability, varus and valgus stress. The neuro, and I'll go over the exam here in a second on the provocative test, and just checking for vascularity. So the main provocative tests for lateral epicondylopathies are Mills, Cozen's, and Maudsley's. And that's because they have been validated. Mills test is a simple test where you have the elbow initially flexed, the hand fully, forearm fully pronated, the wrist fully flexed, and then slowly extend the elbow, and they're going to be tender and painful over the lateral epicondyle. So remember, sensitivity is the ability for us to properly identify the person that has the disease. So it's not the greatest with that, but it is very good at ruling out the person without the disease. So the specificity is 100%. So Mills is a pretty good test. Again, it depends on which muscle's involved. There's not just one muscle here, mostly ECRB, but the others can be. Cosen's is an active resisted extension test. So you have them with their elbow rest, they flex and radially bend their wrist, and then you forcefully resist their extension. And that's going to be 84% sensitive. Again, that would be sort of picking out the ECRB, radially deviating, couldn't think of it for a minute. The ECRB in particular and the ECRL, but maybe they're not involved. So Cosen's isn't 100% sensitive, but it's not very good if they don't have pain either, because it could be one of the other muscles. And Maudsley's is that middle finger resisted extension, and that's got an 88% sensitivity. Again, that could be the extensor digitorum as opposed to the extensor carpi radialis brevis. So that's why there's probably some lack of perfection there. But we do all of those just to be sure. Now, pulse is kind of interesting. There's kind of two phases for pulse. One's for the lateral and one's for the medial epicondyle. So you would fully pronate the forearm and then grab a book or put a 5-pound weight in their hand. And that makes them forcefully extend, just like Cosen's does. It's not been validated though, but it's an interesting way to look at it. Now with PIN, what I do with my patients is I just have them give me the love sign. If they can extend the wrist and put out in full extension their pinky and their index finger and their thumb, then they don't have weakness of the posterior neurosseous nerve and the muscles that are innervated by that. So then we move on to imaging. You know, it's pretty much a clinical diagnosis, but now we all have our point of care ultrasound right there available to us, and it's 100% sensitive and 89% specific, in good hands. That was done in the Journal of Radiology by a friend of mine down the street that also comes and does the ultrasounds on our athletes at the tennis tournament, Dr. Feller. So here's a picture of an ultrasound of lateral epicondyle, and you can see that, as I mentioned before, the tendons aren't as tightly packed as they should be. There's hypoechogenicity here. There might even be some micro tears or cystic structures. There's thickening of the ligament, you know, just scattered areas of either inflammation or hyaline, so the hypoechogenic areas. Then we can get x-rays to rule out other bony or joint pathology. You can see on this middle picture, there's a calcific tendinitis of the lateral epicondyle here. We could look for osseous OCD lesions or something like that on the radial head as well, arthritis in general. And valgus extension overload syndrome, where they may have other foreign bodies and whatnot. So the MRI, if we're looking at OCD lesions, the joint cartilage and the ligaments, and then EMG if we need to rule in or rule out a nerve finding. So the treatment, you know, we wish and we hope we catch these people in the early stages, the acute stages of a tendinopathy, but we often don't actually. But of course, we try to, we always say active rest. As sports medicine doctors, I think we try to, I hope we try to avoid saying you got to shut it down completely, unless they absolutely have to with a bad fracture or something like that. We think of activity modification. What can they do that doesn't aggravate and hurt them? But you know, we've always thought of rest, ice compression, and elevation and anti-inflammatories, but topical Voltaren was examined in the lateral epicondyle, and it showed effective in the short-term relief of pain and improved extension strength. So maybe that's the safest option in the early stage. I'll show you down below there, you see the counter brace. You could use that in acute phase patients as well. As we move into the chronic phase, after several weeks, where it's starting to degenerate, the inflammatory response is gone, we start to wonder if the anti-inflammatory work that we do makes any difference. But again, topical Voltaren gel is helpful in the short-term relief of pain and increase extension strength, so it's useful even here. But then we add like a counter brace that has also been shown to provide significant reduction in frequency and severity of the pain in the short term, and in the long term, some improved function as well. So just continuing on with the counterforce brace, they did do further studies on that I've looked up that show that's the same study there on the top, but the bottom one showed that they compared putting a wrist splint on a person versus a forearm strap for the counterforce brace. And they showed the wrist splint actually had better pain relief. I think that's a little bit more restrictive. I did have a Marine Corps general in the old days that told me that he shook hands all day, hundreds of people every day, and got lateral epicondylopathy. So I put him in a wrist splint to make him aware and make whoever you're about to shake hands with aware to not do it. And that really helped. But I think in most of our athletes, the counterforce brace is maybe the preferred way to do it. The other therapies, I think the point to be sure I get across about physical therapy is that monotherapy was no better than placebo. So, I've had the unfortune to work with patients with HMOs where I'm forced to send them to a certain physical therapy place, and they come back and they tell me they were worthless. They put a heating pad on me, so monotherapy is not helpful. So it's hard to do double-blind controlled studies on all of these things, but let's go through some of them. Dry needling. Conclusions were that because there's low complication rate, dry needling is a safe method and might be effective in treatment. So that's as good as they've gotten for conclusions on dry needling. It did reduce some pain and some function, though, compared to the standard therapy, they called it. E-stim, so that's driving current through the affected area and improving, it shows improvement in grip strength and functional status in patients with lateral epicondylopathies. And then Ionto is where you put a steroid like dexamethasone in one side of the e-stim electrodes, and you drive it towards the other side into the affected area. And not a lot of good research has been done on lateral epicondylopathy with that. But again, I see it a lot with our professionals come through, and the physios that travel with them come in and ask us for dexamethasone every year. We give them 20 of them and they get through it, and they ask us for more. So they're doing it a lot. Eccentric exercises also improved pain scores and muscle strength with the use of eccentric exercises. What I do, some patients don't want to go to PT, they're just not committed, but they'll do something at home. So I say, hey, get the TheraBand Flex Bar, read the instructions perfectly. Do not fudge on it. Do the instructions exactly as they're taught, and you get the patient to twist that flex bar into extension on the affected side, and then they slowly release it to get the eccentric exercise. They repeat it over and over and slowly grow strength without any vibratory force like with a racket would do. The Graston technique, using those stainless steel tools with deep massage, they get out trigger points, they work on adhesions and scar tissue, and there's some evidence that it reduces pain and improves function. I wouldn't be a good osteopath as I am if I didn't mention a manipulation technique. There's a Mills technique similar to the Mills test where you pronate, fully flex the wrist, and then actively in a high velocity, low amplitude technique, straighten out or extend the elbow. You release some tension in the elbow and across those extensor tendons because you have those in max stretch. improved function and pain with that technique. The ones that do not seem to have any evidence behind them are KT taping, but again, you see it. So I wanted to mention it because the physios love it. The players love it. I've even had players interrupt their matches to ask the physios to come back out and reapply the KT tape because it's coming loose and they think it's so valuable. You know, there's lots of good theory on how it works, you know, with fascial layers and putting some on stretch or releasing some fascial attention. We may see more on that. Massage, not really much evidence. Ultrasound, not much evidence. And the Cochrane research I did on acupuncture said no firm conclusions can be drawn about lateral epicondylopathy either. So keeping on in a more aggressive treatment now, the steroids versus the PRP, also extracorporeal shockwave therapy and surgery. So steroids are good. You know, I did it for 20 years before we started doing PRP. And we still talk to patients, give them full informed consent, talk to them about going to, you know, get their PRP, which costs some money, not covered by insurance, takes, have you do you're a little more downtime from that. But some patients with all that informed consent and maybe us saying, well, we could do a steroid shot and then if you go to physical therapy, maybe you won't have the pain return later. But the steroids are really good short term, but 2 to 4 months later, often the pain starts to come back. Whereas the PRP, there's much better long-term data. I'll show you some studies on that. Extracorporeal shockwave therapy, you know, we hear a lot about it. We're reading on it. There's some level 4 evidence, which is, you know, large cohorts of people on Achilles. There's very little research on lateral epicondylopathy so far, but it's being done. I won't tell a full name, but one of the Williams sisters just 2 years ago said, I want to do extracorporeal shockwave therapy on my elbow. We don't have any people in this town that does it. We found a doctor in LA about 2.5 hours from here that would do it. And she jumped on her airplane, had it done, and came back the same day. So you don't want to think too cheaply sometimes. Surgery. So surgery is absolutely an option for the patients that have tried everything conservatively, including the above, for 6 to 12 months, and they've failed. If they resort to surgery, the surgical outcomes are quite good, 85 to 90% effective to return to pre levels of activity. But it's not a PRP talk, but I just want to talk about that quickly. So we're all on the same page. You know, it's autologous blood, it's centrifuged down, we get the Buffy coat, and we re-inject that into the places of tendinopathy in this situation. We may potentiate new growth of type 1 collagen. And there's further discussion going on now in our world with leukocyte-rich and leukocyte-poor PRP. So do we want the leukocytes or do we not want the leukocytes? Leukocytes tend to be more inflammatory. So do we want an inflammatory reaction to kind of start all over again and get an inflammatory, get the macrophages in, get those cytokines going? Or do we not? So like in an arthritic knee, we would probably not want leukocytes in that PRP, but we might choose to put them in a completely stalled, desperate person with lateral epicondylopathy. Not that much research yet done on those choices. Just likewise, the platelet lysate. What we're doing here is the platelets also have a plethora of growth factors and mediators and cytokines in them. So if we use a lysate, we can cause apoptosis of those platelets and release even more of all of those healing mechanisms that we're looking for to restart that process, maybe to get some more normal collagen type 1 fibers back into the lateral epicondyle. So, you know, the downsides are it's expensive, it's not covered, there's some more downtime. But the initial thought was that these studies were poorly done and that there was a research bias. But now, or starting back in 2011 with Gosens, he took 100 people, gave 50 of them cortisone, or 51 of them cortisone and 49 of them PRP. And in the double-blind study, he showed that after 2 years, the PRP was better. Then in 2017, this study compared PRP and steroids at 1 and 2 months, and they were both doing very well at that point, but then there was less pain and improved function at 6 months with the PRP group using the VAS and the DASH scores. Those are the common tools used to measure function and pain of people with general arthritic or joint issues. And then this study was actually done by Dr. Wolf at University of Denver. And she did a study where they pulled together 4 studies. They weren't actually able to do a meta-analysis because they weren't quite done the same, but the conclusions were that the PRP had more favorable pain and function outcomes than whole blood or than cortisone injections at 1 and 2 years. And by doing this kind of a study, it raised the level of and the strength of evidence to a level 1B. And then this final one here that I'll talk about was in 2018 Journal of Orthopedics, that showed that not only was it an effective tool for reducing the symptoms, but it reduced the need for surgical intervention too. Okay, so medial epicondylopathy, again, much of the research is done on lateral. So we're going to talk about more about the presentation and the exam on this, and kind of repeat the treatment options quickly. But it's considered nicknamed many things: golfer's elbow, thrower's elbow, javelin, pickleball now. They're trying to forcefully flick with their wrist because they have to move quicker. The balls, you know, if you don't know about pickleball, the ball is like an old-fashioned plastic wiffle ball. It doesn't have much bounce. So you have to really hit it off of your racket. So if you're a little late, you have to really use your wrist. So we see a lot of people with injuries from pickleball, and we love it for our clinic. But we do get them better. So remembering that it's repetitive microtrauma and overload, and there's an attempt at healing, but there's a failed ability to heal because they keep going, and then this occurs. Most common muscles involved in the medial epicondylopathies are the flexor carpi radialis and the pronator teres. Again, it's much less common than lateral epicondylopathy, but it's the same 4 to 5 decades, although we see it in a younger age if they're really aggressive athletes, men and women. Also, don't forget the workers. It might be a training error. They might have increased too fast and too much. It might be a technique error. And so we always make sure we consider that and get the coach involved, the physio, the athletic trainer, depending on what level they're at, before we return them to play. Similarly, on the differential for medial epicondylitis, cervical radiculopathy, ulnar collateral ligament insufficiency medially. On the ulnar side, we can entrap that cubital tunnel. We can have snapping elbow, little Ehlers elbow, stress fractures, valgus extension overload can hurt laterally, posterior medially, median nerve entrapment, AIN. So we'll talk about that in the exam. Osteoarthritis, OCD lesions we talked about, and then is it something more systemic, something metabolic? So on the physical exam, swelling, ecchymosis shouldn't be there with this because this is a chronic overuse injury, not a trauma. But you know, you never know if they fell or somebody, you know, if they're playing doubles, pickleball or racquetball, they could get hit. But palpating over the medial epicondyle, they'll be most tender. The range of motion should be full. We got to check for that. Flexibility, I mean, stability should be stable for that, but we're checking it to make sure we've thought about the differential. Neuro exam, sensory, motor, function, I'll talk a little bit more about here. And then vascular. And then the provocative test, again, not validated, but pokes. If you turn the wrist into full supination and grab a book, then you're forcing that person's wrist to forcefully flex to hold that book up. So that is potentially going to fire the medial epicondyle. OK test is, nicknamed many different things. There's benediction signs. So if you're unable to fully flex those fingers, you can only flex them somewhat. And it's kind of like a priest blessing you. So they call it the benediction sign. This is also known as Fromet's test, where the anterior interosseous nerve innervates the flexor carpi, the flexor profundus tendon. So the distal DIP should be able to flex of the finger, and the flexor pollicis longus, so flexor digitorum longus and the flexor pollicis longus. So they should be able to touch the tip of their index finger when they flex the to the tip of their thumb. But if they're unable to do that because of weakness, they'll touch, and with extended fingers they'll touch. So some say this is now called the rabbit sign and the fox sign. So it looks more like a fox than a rabbit if they're abnormal. So Fromet's test, the OK sign, I guess that's kind of politically incorrect to do nowadays, but in the office, I guess we can do that. So what are the tests? Again, it's kind of a clinical finding. The X-rays can help us to differentiate other concomitant injuries, or do we have the correct differential? MRI, EMG if necessary. Here's the ultrasound that we can do right in the office with the patient. We see hypoechoic areas, thickened ligament, less dense fibril, tight areas, some maybe micro tearing or intersubstance tearing of the tendon. Here you see right at the footprint of the tendon, some hypoechoic areas, thickening of the ligament, and intermittent hypoechoic areas of the ligament. So in acute phases, just like the lateral, we'd try to relative rest, not complete rest, rest ice compression, probably Voltaren gel would be the best option here. Anything, superficial enough that it'll penetrate to the tendon might be helpful. We've already talked about each of these. Again, monotherapy is the mistake to make. And steroid versus PRP, we're making some extrapolation here that the PRP is better than the steroid in the long run. Surgically, there has been studies done on medial epicondylopathy, and it's just as good, basically, if they resort to that after 6 to 12 months of failed conservative management, which should probably nowadays include PRP because it is quite helpful. Distal biceps tendinopathy, I won't spend much time on. It's very rare, older decade, dominant arm, more in men. Unanticipated sudden load of the tendon, but it doesn't fully tear the tendon. So we'll talk about that in a second. But gymnastics, where they're falling, but they try to stop themselves. Rock climbing, where their leg slips and they try to stop themselves so they can sort of suddenly partially tear or cause micro tears if they're just doing it over and over and over. And my daughter used to have to do, hundreds of pull-ups every day in gymnastics. So we talked about the repetitive microtrauma, good enough. So differential is whether they do have tendinopathy or do they have a partial tear or a complete rupture. Is the pronator teres, because it's so close nearby their anterior midline. AIN, same sort of location. So just making sure we're thinking of the other differential. They're going to have pain and discomfort over that distal biceps tendon in the anterior midline of the elbow, exacerbated by flexion and supination, tenderness. So their pain and they're tender over that area. They're going to have a normal neuro exam. They're going to have stability of the elbow. Should have full passive range of motion. They may not want to forcefully flex. And then ultrasound, we can look at the tendon and see how healthy or unhealthy it is. So diagnostic, point of care ultrasound. X-rays to help rule out other things, MRI if you think this could be a full tear, and full tears do better with surgery, I'm going to get an MRI to see. And it's almost always treated conservatively, and initial treatment can be the same as rest, relative rest, icing. Topical anti-inflammatories may not penetrate deep enough, so PRP, if you've tried some otherwise physical therapy and conservative management and that fails, I would go to PRP before I'd go to surgery. And then the ruptured biceps tendon, again, generally old males, their dominant arm, older men. one-time trauma. This is not a tendinopathy. This is a rupture. They often hear a pop or a gunshot. They have tenderness, ecchymosis in that anterior forearm. They'll have Popeye sign, and you guys know the hook sign, so that should be absent if you actually did tear it. You won't be able to find that the tension of the long tendon. Can be pretty much a clinical diagnosis by the story and the exam, and then ultrasound can help you find a raveled up, torn biceps tendon. MRI if we want to help the surgeons decide whether to go to surgery. Look for other concomitant injuries. Remember again the tears. Anyway, I talked about this. I meant to mention this earlier. The watershed area of the middle portion of this tendon. So there's good blood supply by the recurrent nerve arteries to the distal tendon as it attaches into the radial tuberosity. There's some good blood supply at the musculotendinous junction, but that midsection doesn't get a great blood supply. So that's partly why those partial tears might not heal well and might need some PRP. But the people that fully tear their biceps tendon do really poorly if they don't have surgery. So if you look at the bottom there, non-operative management, 40% loss of flexion, 50% loss of supination power. But if they do go to surgery, there's only less than a 2% tear rate. It takes quite a long recovery time, but most of these people, again, they're older, so they don't have to go back to, professional sports necessarily, can get back to pretty normal activity with a surgery. Triceps tendinopathy, also pretty rare, often middle-aged men that weightlift. Mountain bikers, they have to forcefully try to extend their elbows so they don't get compressed every time they go over a bump or a rock. So they're constantly getting gripping the handlebars, getting a vibratory force, and they're trying to extend their elbows so they might get the tendinopathy of the triceps tendon. Less common injury, least common of all these injuries that we're talking about in tendinopathies. It's right generally at the distal tendon as it attaches to the olecranon. It's more common with people with diabetes and hypoparathyroidism, metabolic issues. The differential, again, lateral epicondylopathy, could be the anconia, so it's sort of posterior where the tricep is. We talked about the triceps can sublux, and the snapping elbow syndrome can be medial, so the triceps could be faking you out. So we'll want to think of the full differential here. Posterior elbow impingement, flexion, contracture, do a full range of motion test. Arthritis, OCD can hurt in the posterior portion over the olecranon portions, olecranon bursitis. Synovial plica, if that exists, I've really never seen that in elbow. That's more knee issues for me. Snapping triceps, we talked about in valgus extension overload, can kind of hurt anywhere. Posterior elbow, pain and tenderness exacerbated by forceful elbow extension. There should be no laxity. They should have full passive range of motion unless they let it go too long and there's other concomitant injuries. We can slap the ultrasound on there and see all these changes that we talk about with the other tendons, x-rays to rule out other problems, and MRI if they're failing to improve, and they might have partial tears. You might want to do PRP, etc. And that's the same sort of treatment. These should always be managed conservatively and should come through that within 10 to 12 weeks with pretty much the same thing. Physical therapy, again, doing multiple different things of physical therapy to help the patients, and maybe even eccentric exercises there. The supinator, I'm not sure I have much time left. Supinator, we talked about on that lateral epicondyle, coming and rotating around into the distal forearm, wrapping around the anterior portion of the radius. In and of itself can be the cause of lateral epicondylopathy, but it can be a strain in the muscle, strain in the musculotendinous junction of that muscle. So it can be isolated, doesn't happen very often. Like I said, rarely injured by itself. Remember, the posterior interosseous nerve is in between the two layers, the deep and the superficial layers of the muscle. So think about, do they have good full strength, and can they do their love sign with sign language? Remember, it works in flexion with, it works in supination with the biceps when the elbow's flexed at 90 degrees. And it receives its innervation from the radial nerve itself, directly from the radial nerve, not from the posterior interosseous nerve. So they should still have good supination there. You're going to have pain and tenderness with forceful resisted supination over that lateral epicondyle or the proximal lateral radial head. Almost always managed conservatively within 4 or 5 weeks. Ice and probably topical anti-inflammatories, physical therapy, multiple modalities, and they should respond to conservative therapy and go back to return to play in 12 weeks or so. And then the pronator teres can likewise, on the medial side, with rotation, get entrapped or get tendinopathies form. It is really part of medial epicondylopathy, but it could be down in, like I said, the musculotendinous junction of the pronator teres. So it's rare by itself. It's interesting. It's only been reported so far in golfers and cricket players. So we're really getting down to the nitty gritty here, like you specialists need to do. So repetitive pronation, elbow valgus stress. It happens to hurt in late cocking and early acceleration. And the exam will be over that medial epicondyle or just distal to that, pain and tenderness, pain with forceful pronation. Ultrasound can be put there, and we see those typical ultrasound changes of the tendon, x-rays to rule out other things, MRI if you think there might be partial tears or other injuries. And then the treatment is conservative mainly, and 4 to 6 weeks to return. Shouldn't need surgery. And that's the end of my talk, folks. So happy to take on any questions. I guess I need to unshare. What do I do here?
You don't need to do anything, Dr. Steele.
Okay.
So thank you for this talk. So we have some questions that have come through. So without further ado, I don't want to hold up everybody. We're going to try to get through some of these questions here. So the first question is, in some of the chronic lateral epicondylosis cases that are refractory to prior treatment, have you seen people use Botox?
I have not seen any research on that whatsoever. I think I saw one of our email conversations that we have with the sports medicine doctors discussing that at one time, but don't have any experience with that. Sorry. I don't know if you do, if you read anything.
No, I have never used Botox in it. I haven't seen any evidence or any case reports on that. You know, people in the audience, please educate me if I'm wrong on that. But typically, as you have said, the most evidence is in PRP. So the next question is regarding the steroid injections for lateral epicondylopathy. There has been literature saying that steroids have short-term improvement, but actually lead to worse long-term outcomes. Could you comment a bit on this?
Yeah, again, I've been doing it for 30 years now, and I only had cortisone for a long time. A good number of people come back and say, yeah, that was great, but it's back. But a lot of people don't come back. So again, I try to give people informed consent. I think we even talk about that with most of them, that there might be some injury that's induced by the cortisone. And I think that's certainly a concern, but it's been used for a lot of years. I'll be happy to hear anybody else's comments on that.
Yeah, so my experience has been, you know, cortisone provides short-term relief as well. Sometimes, you know, if you get it in the tendon, that needle tenotomy can oftentimes induce, you know, some healing responses. So maybe that's the case. I'm not exactly sure. All right, next question. I think Dr. Bauer has answered. It was regarding the role of Tenex in tendinopathies currently, and if there's any evidence. Dr. Bauer has already posted a link to the study that his colleagues did at Emory that did show PRP and Tenex both showed good results in pain, function, and quality of life. Anecdotally, Dr. Bauer also has noted good outcomes. So next question is, what would you recommend as the proper technique in injecting the lateral epicondyle with corticosteroid or PRP?
Well, so I've kind of done it for a long time. This is anecdotal for me, but what I do is I give a little lidocaine first, just a bleb, and I go a little bit deeper too with the lidocaine separately. And then I do a little multi-pronged, several fanned out injections and spread the medicine out. Again, I'm sort of thinking of dry needling. I'm doing dry needling as I'm doing the PRP or the cortisone. So my technique is to kind of think of a nickel down underneath the skin at the tendon, and I try to spread the medicine and do multiple passes with the needle.
Yeah, that's typically how we're taught. Landmark guided or landmark based, ultrasound guided. Obviously, we can do it a little bit more, just effectively and pinpoint accurately. So next question, we have two more. I want to get through these because I think these are interesting questions. The next question is, do you notice any difference in the effectiveness of PRP based on the stage of tendinopathy, whether it's acute, subacute, chronic, or severe? And is there a point that is too late for PRP?
Definitely see that. When it's degenerative, there's even likelihood that they're going to end up with surgery. So the PRP is kind of the last ditch effort. I'd say a good percentage of the people that have had it for 2 or more years probably end up in surgery. But the PRP has been very nice for a lot of these people. So I say yes, there's a definite correlation with how long it's been there and what phase it's in as to the response to PRP.
Yeah. All right, we're going to wrap up with the final question today. And it says, this question is, how about topical nitroglycerin patches? Any recommendations from your experience for tendinopathies in the elbow?
That's a good one. I think there's been some good research on the Achilles, and we've used it. I think there's been a couple of research papers on the lateral epicondylopathies. I didn't really research it well enough for this talk, so I'd like to hear anybody else's thoughts on that too.
Yeah, so I've used it, although I full disclaimer, I work in a military facility, so we try to get them back as much as we can, also considering the evidence. But I have used it in the past. It doesn't work as well on the as opposed to the Achilles. So Achilles works pretty well, but I haven't seen it work as well in lateral epicondyle or medial epicondyle or even triceps. But yeah. So thank you for Dr. Steele for giving this talk. It was a great talk. It was incredibly educational. And thank you everybody for joining us. I don't want to hold everybody,
Thanks, everybody.
late tonight. So thank you.
Send me any comments.